Good morning, everyone. Thank you very much for joining us. We know this is a slightly unusual time for those of you who've been tuning in at our 6 o'clock briefing sessions. I'm delighted to tell you that we're going to be talking about diagnostics in today's session, and my colleagues will introduce themselves when they speak. So without further ado, let me just whiz through the slides. So today we are asking you please to keep your microphones on mute and to turn your cameras off, because this just helps us with our bandwidth. And questions should be submitted via chat. You don't have to wait till the end of the session. If you've got a question, please send it to West Herts Communications, and we will make sure that we allow time to answer your questions at the end of the presentation, and we aim to be finished before 11 o'clock or around 11 o'clock. We are recording this session and it will be uploaded onto our YouTube channel. So the aim of the session is to give you a little bit of background on the redevelopment and really our proposals to deliver new services across our 3 hospitals. In particular, this session looks at diagnostics, and we will also talk to you about our engagement programme and make sure that you have an opportunity to ask questions in the session and also give your feedback via the survey. A little bit of background for you. We have been trying for some time now, years, well, decades really, to secure the kind of investment that we think is needed to make significant improvements to our estate. And we now have an agreement in principle that significant investment is coming our way. So in September 2019, Prime Minister Boris Johnson announced that we were one of 6 hospitals in the health infrastructure plan. Time has moved on a little, and there are now 8 frontrunners, and the programme is more commonly called the New Hospital Programme. We're absolutely delighted to still be in that first group of hospital trusts who are going to have massive investment. But it's not quite as simple as the Prime Minister saying that the money is coming our way. We have to now work up our outline business case and submit that to our regulators. And there are quite a few of them: NHS England, NHS Improvement, Department of Health and Social Care, and of course the Treasury. So a lot of work to do to show that our case, our application is strong, it represents good value for money, and it can be delivered within a timescale of 2025 or soon after. So if you've been to our sites, you have, I hope, had really, really good care, but it's harder to ask if you've been impressed with the estate, because our buildings are really past their best. So we want to now work as quickly as we can to deliver far better buildings to you and to our amazing staff. So Your Care, Your Views is the name of our public engagement programme. There are a suite of documents, 4 documents that you can look at to gather some more information about this. And depending on how much detail or what perspective you would like, there are different documents. So the clinical strategy is really where all of this starts, and our strategy reflects national strategy as well as local and regional strategy. That document has a pragmatic partner, the clinical brief, and that's the one to look at if you really want to get under the skin of all these proposals and understand where different services might be moving to. And then there are 2 engagement documents, and the reason there are 2 is that there is a summary. So if you're really short of time and you just want to get a flavour of what it is that we're doing, then the summary is probably the document for you. But if you can make time to read them all, that would be great. And we are running a survey to find out what your views are about our proposals. And the deadline is coming up, and it is midnight on the 24th of March. So please, please, please have a look at the survey. It won't take you too long, I promise, and send us your feedback. So we have a couple of sort of sayings or phrases that really sum up what is at the heart of our proposals. And Three's company, well, we know it's really Two's company and Three's a crowd, but we actually think that 3 is company when you consider our 3 hospitals. We think they can work really well together and complement each other. But to make this work, we do need to make some changes to give each hospital a unique purpose. And the broad outline of the 3 hospitals is for Watford to remain as the site for emergency, specialist and complex care, for St Albans to be our site for planned care, planned surgical care and an urgent care service, and for Hemel Hempstead to be our site for urgent and planned medical care and care for people with long-term conditions. So really a multi-specialty site. Now the asterisk there next to St Albans just recognises the fact that the minor injuries unit is currently closed, and when it reopens, we do expect it to be offering a slightly broader service, more along the model of urgent care that is provided at Hemel Hempstead. So another phrase that we use to really think about what our proposals are based on is to consolidate and not duplicate. And when we knew that we were in line for investment and we began having conversations with our clinical staff about how we could best improve our buildings and our services, the message came back loud and clear that we were stretching our teams a little bit too thinly across 3 sites, and that we could deliver a better service if we thought about making services which run across 3 sites now run across 2, and in some cases services that run from 2 sites to be based at 1 site. And the benefit of consolidating staff groups along specialty lines, so really around the services that they provide, is that we can improve their training and development. They can learn from senior colleagues and importantly seek a senior clinical opinion face-to-face when that's needed. From a patient point of view, having a broader, bigger team together means that we are far less likely to need to cancel a clinic or an appointment because of an unexpected staff shortage. Also, having teams grouped together means that we can make far better use of our diagnostics, which is something that we'll hear about a little more in this session. So we think it's a really good way of working across our 3 hospitals. There is one thing to say about these proposals, though, is that the focus of providing the best care at each site does mean that the hospital closest to you isn't always going to be the best hospital for you to go to. So it all depends on what your clinical needs are and what each of our trusts, each of our hospitals is providing. So digital transformation is one of the enablers for all of this work, and things are changing already. Hardware and software is being replaced. We're now taking our first steps to get ready for the electronic patient record, and we are also doing a lot more consultations using software like this, like I'm talking to you today. So the advent of COVID really shifted a lot of our consultations to online platforms. This is something we were looking at anyway, but it has really sped up our work in this respect. We have cared for over 4,000 patients through a virtual COVID hospital, so we know that a great level of hospital care can be given to our patients, and the statistics coming out from that and the clinical outcomes are already looking really, really good. And pleasingly, the views of patients, their feedback is that virtual appointments have worked really well for the vast majority of patients. They can save a lot of time and effort travelling to our sites, and they can impart information quickly and easily. And also for some patients, they can have carers on the call or other people join them on the call who would otherwise be hundreds of miles away. So we're seeing lots of benefits to digital transformation. We know it's not for everyone and it won't be compulsory to engage with us in this way, but for many patients it is really proving to be very helpful. And another enabler is, of course, the diagnostics. So I'm going to hand over to Shilpan Patel. And Shilpan, if you can introduce yourself and then take it away with the slides, that would be great. Thank you. Shilpan, I think
Sorry.
you're just on, yeah, thank you. I'm sorry, Shilpan, we can't hear you at the moment. We're just going to check whether we need to.
No, it's me.
Okay, all right. All right, you're off.
I'm Shilpan Patel. I'm a clinical director at West Herts for radiology, and I have been since the 1st of April last year at the beginning of the pandemic. I'm just going to run you through a few slides and pick up on some of the points that Louise has kind of commented on as well earlier. And I'm just going to get the screen up. Okay, so just going to share the screen. Bear me 2 seconds, sorry. Can you guys see that?
Is it different to our presentation, Shilpan?
No, it's your presentation.
We will drive, then Sarah will keep going with the presentation as you talk.
Okay, so essentially a lot of what's happening at the 3 sites kind of stems from the National Diagnostic Strategy, which was published last year. And prior to the pandemic, it was quite evident that a lot of NHS long-term plans around cancer, heart disease, stroke, respiratory diseases, and the reform of same-day and emergency imaging had to happen. And the COVID pandemic really put that into sharp focus. And what had been happening was that there was a kind of annual increase in all kind of different imaging modalities. So that includes things like X-ray, CT, MRI, year on year. And this strategy that is being put forward basically will help us address some of those things. Now, in terms of, if we just go back 1 slide, in terms of where things are going to be based, at Hemel we'll have the full range of diagnostic services in terms of plain film, X-ray, ultrasound, CT and MR. And we're also hoping to create a rapid diagnostic centre at St Albans Hospital, offering CT and MR, and the proposal is really to have all imaging in one place. And as Louise said in an earlier slide, having staff together in one place is easier to then manage how we run our services. And at Watford, obviously, by creating new facilities, we'll be able to fulfil some of these NHS commitments in increasing the number of CT scanners by 100% over the next 5 years, replacing any scanner that's older than 10 years, and being able to separate out elective and acute work. And that, as I said, was brought into sharp focus during the pandemic. Just going to go back to slide, sorry. So if you could go on to the next slide for me. So in terms of diagnostics, I've got used a few jargon terms, which I shouldn't, but there are lots of different types of imaging that are in the X-ray department. So it's not just confined to X-rays. X-rays are a simple imaging modality that is used in the X-ray department, and it uses X-rays to generate images of bones so that we can look for fractures, but it also is used to help identify infections on chest X-rays, for example. Ultrasound works on the premise that an ultrasound beam is kind of pushed into the body and is reflected back, and depending on what is reflected back, you generate an image of inside of the body, and we can use it to scan the neck, we can use it to scan the abdomen, pelvic organs, and we can actually even use it to help guide the introduction of needles to take biopsies, and to help patients that are suffering from pain by injecting painkillers into joints to kind of prevent any kind of problems in terms of pain. Another imaging modality that's used in X-ray is fluoroscopy, when a continuous X-ray is used to look at the body. So an example might include a barium swallow test, in which a patient would swallow some dye, and the X-rays would be continuously be taken, and we'd be able to look at how that passes through the body. And ultrasound is not only used in a non-obstetric setting, it's also used in an obstetric setting to look inside a lady's body and to look at the baby that is present. Can we go on to the next slide, please? CT is it also uses X-rays, but uses X-rays using a rotating machine, and that allows us to build a three-dimensional image of the body. And that's really useful in the acute setting for looking at, for example, identifying any acute bleeds in patients that may have fallen over, but it's also used in cancer diagnosis and in assessing patients that have sustained trauma. Nuclear medicine, we already have at some of our sites, but that involves the injection of a radioactive tracer into the body, and it can help us identify sites of disease and look at the function of organs. So, for example, we use it to look at the function of kidneys and which kidney is providing how much. We can identify how much each kidney might, for example, contribute in terms of function. If you then merge the nuclear medicine with a CT scanner, that's known as a SPECT CT, and the benefit of a SPECT CT, which we currently don't have, and we will have with the new facilities, is that it allows the radioactive tracer, which ordinarily you would see a two-dimensional view of the body, to be fused with the CT scan and to provide really clever detail as to where pathology might be in the body in a 3D plane. In our X-ray department, we also use mammography, which are low-dose X-rays, to examine the breast for patients as part of the national screening program to identify breast cancers, but also in patients that are symptomatic that have come to the department with breast lumps. If we could go on to the next slide. MRI, we will have provision for MRI with the proposals at all three sites. MRI has the advantage over CT in that it doesn't use any radiation and is very good at exquisitely looking at different soft tissues within the body. And so it has a number of applications. It can be used in the brain to look for any acute pathology such as strokes. It can be used in the body to look for to look at cancers and to allow clinicians to get a really accurate idea of what's going on in terms of patients that have been diagnosed with cancer so that they can get the right treatment. And it can also be used to look at a number of joints. So, for example, the knees, the shoulders in patients that have orthopedic and rheumatological conditions. DEXA scanning is a very specialized type of X-ray which really accurately measures bone density. Now, we know that our population is getting older and more patients are suffering from the problems of having reduced bone density as they get older. And if the bone density is reduced, they are more prone to get fractures. So this type of scan is very good at identifying how dense the bone is. And that's something that affects ladies as they get older, more so than men. Interventional radiology is something that a trust of this size really requires. There are a number of procedures that can be performed in the interventional radiology department which would save the patients from having to go to surgery. It can also kind of have very advantageous effects. So, for example, if a patient was pregnant and after the pregnancy and it delivered a baby that had heavy bleeding, you could go to the interventional radiology department to stop the bleeding without the need for surgery and preserve the womb. And that's something that we are pushing for, not only with the new hospital facilities, but also currently we're pushing to get a new interventional radiology suite or IR suite. Cardiac MR. So cardiac MR is also an MRI scanner, but it has some more specialist software bolted onto it, which allows very detailed views of the heart. And that's used to look for various different pathologies and gives much more detailed information than echocardiograms can give. It's a very specialized piece of equipment, and West Herts was one of the first trusts in the country to both get cardiac CT and cardiac MR. And the plan would be that in the new hospital facilities, there would be, again, provision for that. And that has certainly kind of improved cardiac care for our patients. Endoscopy and cystoscopy are mentioned on this slide, but have been covered in separate sessions. And And without kind of going into repetition, there are YouTube links for that, which would help with that. And I know some of you have attended some of those workshops already. So if you could go on to the next slide, please, Sarah. So in terms of future plans, at Hemel Hempstead, it's going to be our proposed centre for planned medical services. Now, we know that our population is ageing, and they have lots of different pathologies. And sometimes the patients that would be kind of cared for at Hemel Hempstead Hospital would be those patients that wouldn't necessarily need any surgical intervention, but would need the full kind of range of medical support. And having all the medical specialties in one area would help these patients. So, and specifically bringing lots of different aspects of patients' care together. So bringing together primary care, so GPs, community care, mental health and social care partners together would help us deliver a better model of care for our older patients based at Hemel. And they would be supported in terms of diagnostics, because we would have the provision for plain X-rays, ultrasound, MRI, CT and DEXA scanning. So they would have more or less the same facilities as they would at Watford, for example, without the need, without interventional radiology, because they wouldn't be as acutely unwell, but would still require inpatient support. Go on to the next slide, please. So what do our clinicians think? This is a quote from Sandeep Ballara, who, Dr. Ballara is our consultant rheumatologist and clinical directors for specialties, medical specialties. And it kind of reiterates kind of what I was saying, in that planned medical care can happen on non-emergency sites in a calm environment where you bring together all specialties, and that's supported by having the kind of range of diagnostic services that we would provide. If we go on to the next slide, please. In terms of St Albans City Hospital, the plan is to kind of improve our theatres at St Albans so that we can, and that would be supported by extending our range of diagnostics. And St Albans would be the main cancer diagnostic site where patients can access a range of services. So one of the things that is being proposed is that there'll be more one-stop pathways based at St Albans. So I'll give you the example of the blood in the urine or hematuria pathway. By having the clinicians, diagnostics, cystoscopy all in one place, it would allow patients to visit one site, have all their investigations, see all the relevant clinicians, and then get an answer quicker. And again, diagnostics would be supported by providing X-ray, ultrasounds, fluoroscopy, but because a lot of our breast services are based at St Albans, mammography, nuclear medicine, MRI and CT would also be there. So again, you can see there's quite an extensive range of diagnostic services in X-ray that are being provided, not only at Watford, but also Hemel and St Albans. So I'll bring you on to the next slide. And this is Mr. Banks. He's our Associate Medical Director for Strategy, and he's one of our senior clinical urologists. And he basically said that it can be a challenge because sometimes patients come and are seen by clinicians at one site. They have an outpatient appointment somewhere else. They then might come to have a biopsy at another site. And all of that requires traveling to lots of different locations. And that can be stressful for both the patient and the team that are looking after patients. And by kind of consolidating all of that at one location at St Albans, it's hoped that some of these pathways can be really streamlined, reduce anxiety for patients and kind of improve their experience. Just go on to the next slide. So what are our future plans? So Watford will continue to provide extended and improved emergency care, but will also provide a range of specialist care services. The new plans are very exciting in that there'll be a significant expansion in diagnostic services in terms of the number of scanners that we'll be able to provide. And that will allow us to separate our acute and elective work much more easily. And that's beneficial for patients so that, you know, the acute and inpatient patients are separated and they have a different experience from those patients that are coming in electively to have their outpatient investigations. one of the exciting things that's also happening at Watford is that for the first time, we're going to have all of our services based in one footprint, one area. At the moment, we're fragmented across the hospital in 2 or 3 different areas. And as Louise said, there are efficiencies to be made by having staff all in one area. And it's also better for patients by being able to go through the department and then having, again, the full range of diagnostic services, which would include X-ray, ultrasound, CT, but also the cardiac CT and cardiac MR. Nuclear medicine would be upgraded with the new SPECS scanner, which we've never had before, and fluoroscopy. And just a little bit about Watford, in the future, the Mount Vernon Cancer Services may also come onto the Watford site, and so PET CT would be offered potentially as well. We go into the next slide. So this is just a quote from Vicky Houghton, who's our intensive care matron and chair of the Joint Staff Consultative Committee. And she talks a little bit about our experiences over the last 12 months and what COVID has taught us. So there is a need to rapidly expand our critical care beds, and it's also important to kind of have that separation of acute and elective work, which the models being proposed do allow. Like Vicky, I kind of share her kind of, it's a morale boost to see the kind of new plans coming together, the new facilities that are going to be on offer, and, you know, hopefully we'll be able to get cracking soon with this. So I'll hand back to Louise for this part in terms of the engagement plan and pathways.
Thank you very much. Thank you, Shilpa. I didn't realise you joined us in April of last year. So what a time you must have had. So this slide is just setting out our engagement. You can see we're coming to the end of our first period of engagement. And that means that if you haven't had a chance to read any of our documents or do our survey, we'd really like you to do that as soon as possible. We are taking a break between our periods of engagement, and during that time we'll review all of your feedback and we'll consider anything that's become clear to us that is an issue, areas of concern, or where perhaps we haven't been clear enough in our information to you. And then we go back out for a second period of engagement and clarification. And after that, we look at all the feedback that we have, whether it's via the chat function in sessions like this, or in the survey where there is free text space for you to give us your thoughts. Then we give all of that to our board, and that informs part of their decision making for the clinical brief and also for later decisions that will be made in the autumn. So our survey is being or has been commissioned from an independent organisation just to give it a sort of level of impartiality, and also because devising surveys isn't our strong suit. So there is some independence around the survey, not just in how it's been created, but also in how the results will be analysed. And there are still ways to get involved, although the window of opportunity is closing. If we can arrange a meeting for you, we surely would, but we would want that to happen before close of play on the 24th, so that's Wednesday. We can translate documents, we have paper versions of the survey and lots of information on our website. As Shilpan said, there are presentations like this on a range of topics, and many of those have now been uploaded onto our YouTube site. So if you weren't able to get to any of those sessions, or you want to refresh your memory of them, then they are all there for you to look at. So now we have some time for questions, and I can see that there have come in some have come in already, and there's one that is definitely coming your way, Shilpan, I'm sure. If not, I know we have other diagnostic staff waiting in the wings to help, but it's a question about isotopes in connection with the nuclear medicine. And the question is, will isotopes be available domestically from the UK in the future?
Yeah, so I think there has been a lot of work that's been done around isotopes and planning for not only Brexit, but the kind of impact of COVID. So there's been a lot of work that's been done around that to make sure that there is provision for isotopes. There are certain isotopes that we use for the scans that we already do at our sites, but more specialist isotopes, for example, for PET-CT, are generated close to where the PET-CTs are done, and we don't actually have a PET-CT scanner. So those more specialist isotopes, which have a very kind of short period where they're active, they are generated at other sites and then brought in. So that isn't so much of an issue. We work through that.
Thank you for that. So I'm actually going to ask my last question. So if you have a question and you haven't submitted it, then please get submitting it now. And this might be something that Sue might like to ask. So we've got Sue Daniels with us, or Nuala Littlechild, so other colleagues. And it's about staffing, Sue. So I wanted to ask, we've been asked about staffing actually at many of the sessions, whether we're worried about, you know, this seems like an expansion of services, so people then worry about recruiting, and we hear about staff shortages. We've talked about nursing shortages in the past and given some reassurance around that, but what's the situation for diagnostic staff and your level of confidence? And if you wouldn't mind just saying what your job title is, that'd be great. Thank you.
Okay, my name's Sue Daniels. I'm radiology services manager, excuse me. We are fully staffed at band 5 and band 6 radiographic vacancies at the moment. We've done very well in our recruitment. We've got a band 7 sonographer vacancy, but we've had several applicants. So overall, the picture is very rosy. We've got a really good team spirit, and we retain our staff very well indeed. Do you want to add anything, Nuala?
No, I think that says it all, actually. We have done really well on our recruitment. I know the national picture is there is a national shortage of radiographers, but here at West Herts, we've been really successful in our recruitment. So knowing that we've got these new scanners coming on board, we're quite positive that we will be able to recruit the necessary staff to go with them.
Thank you. Well, this is a record, just two questions. So I'm just going to do a quick scan. I think it must be the time is not the normal time. So obviously we don't have quite as many people as we've had before, but an incredibly informative session, and I've learned an awful lot. So I think this is one we will be driving people to when they ask us diagnostic questions, and really good to have some of this information available, because it was quite scientific. So it's definitely one that I will go back and have a look at, just to make sure that I've understood everything. But really, I don't know, inspiring, I guess is the word, to think about all these facilities coming our way, and good to hear from Sue also that staffing is in good shape. So there are no further questions. In that case, I'm going to draw you to the QR code and to the survey, and I'm going to thank my colleagues Shilpan, Nuala and Sue for being with us, and I wish you a good day. Thank you very much.